So, hello everyone. In this video, we are going to read a very important topic which has been frequently asked in NEET as well as INICET in the last year, which is alopecia, which you all know is hair loss. So, we'll discuss how clinically each of these cases present, right? So, we all know the classification. It can be scarring and non-scarring alopecia. We will majorly focus on the non-scarring alopecia in this video since they have been asked more commonly. Coming to the scarring alopecia, just remember a few names of scarring alopecia: lichen planopilaris (LPP) and discoid LEDLE, and of course inflammatory tinea capitis. So we will discuss about inflammatory tinea capitis in the next video. But let us discuss about the non-scarring variant, which have been asked very frequently in the last few examinations. So coming to the first most important, it is alopecia areata. Alopecia areata. Okay. So alopecia areata, how does it present? It will be usually a child or an adult also, like 20 to 30 years, 5 to 6 years of age. So they will be very well defined round to oval patches. They will have really a good shape. They will be smooth. There will be no hair inside them. There will be no hair inside the patches. So you can see very well defined smooth patches, almost no hair inside the patches. And also the inner surface is smooth. There will be sparing of the gray phenomenon, sparing of the gray hair. This you should know, and overnight turning of the gray over is also known as. This is also known as overnight. Then exclamation mark hair. Exclamation mark hair are seen in alopecia areata. Like the distal end will be broader and the base, towards the base, it will be very pointed and it will form an exclamation mark. What do you see in histopathology? You should remember, since it is an autoimmune condition and around the hair follicle we have what? What do we have? These are lymphocytic infiltrate targeted around the hair bulb, right? So these are CD8 T cells. So we will have perifollicular lymphocytic infiltrate. This appearance is also known as swarm of bees appearance. Now coming to the treatment, if it is limited, we can do what? What can we do? We can give injections of tricot. Tricot is the short form. It is triamcinolone acetonide. You should remember these names: anthralin, DPCP. Nothing to know more about it. But there was this question: if it is progressive, what do you do? If it is progressive, means the patient is having newer patches which are not controlled only on the topical treatment. You add oral steroid, and these are what? These are immunosuppressants. Immunosuppressants medications are also given. These are the new drugs. If you want to target ionized, these can be asked: baricitinib, britillacitinib, and deuruxolitinib. These are FDA approved newer treatments for alopecia areata. What else? What else should you know about alopecia areata? What other part of the body you should examine in a patient? You should examine the nails. Why? Why nails? Nail will have fine geometric pits opposed to the psoriasis where we have coarser pits. What else? What else is the important association? There is association of atopy and also an important association of Down syndrome. So this you should remember about the alopecia areata. This is the picture. Very well defined smooth patches, no hair inside it. Some gray hairs are spared, right? Very well defined. Next is trichotillomania. Trichotillomania, how do they present? They will be usually females having some psychiatric disorder since it is an OCD. It is an OCD. So how will you identify? It will not be smooth. It will the patch will be very irregular, very ill-defined hair loss of frontoparietal region predominantly, and inside the patch also the variable length of the hair. This is the term we should remember: variable length of the hair. Can you see? The hair are not equal. Some are larger, some are smaller, thicker, and all those things are there. And if you see this peripheral rim of the hair remaining, rest of all of it is gone. This is known as what sign? This is known as prior tuck sign. This was a cartoon who had only peripheral rim of the hair, right? And what do you see? We see, if you do dermoscopy, right, we see perifollicular hemorrhage and many more features are there. You need not know. What is the treatment of choice? It is behavioral therapy. If you want to know some newer treatment, then it is N-acetylcysteine. This can be a new question. N-acetylcysteine has been tried. This has already come in histopathology and ionized. What is the histopathology? Pigment cast inside the hair follicle canals are seen in trichotillomania, and trichomalacia is also seen. This is the picture showing friar tuck sign and trichotillomania. So how do you identify? Next thing is syphilis, right? Which stage of syphilis first of all has non-scarring alopecia? You should know which is secondary syphilis. It is not primary syphilis, it is secondary syphilis. How the question is framed? There will be young reproductive age male having sexual history and past history of genital ulcers, past history of sexual contact along with genital ulcers which heal, but now he has what? He has rashes all over the body, he has lymphadenopathy, he has palm and soles lesions of secondary syphilis with Buschke-Ollendorff sign, right? Now, apart from that, they will say this is the picture which will be provided to you. What is this? This is known as moth-eaten alopecia of the secondary syphilis. Multiple, these will be multiple patches of the alopecia will be there, multiple patches of non-scarring alopecia along with certain hints. They will ask you what else do you look for? You should say you should look for palm soles, rashes over the body. Okay, what investigation is to be done? VDRL and TPHA. What is the organism? You know, Treponema pallidum, right? Treponema pallidum. And what is the treatment? As per the stage of syphilis, you will treat it as per the secondary syphilis, right? Now, coming to the next entity, it is tinea capitis. What is tinea capitis? Tinea capitis, which tinea capitis has non-scarring alopecia? It is non-inflammatory variant, where the inflammation is not happening. Okay. So we all know that it is of two types, ectothrix and endothrix. What is the difference between ectothrix and endothrix? So in ectothrix, what happens? The fungal elements are inside the hair. They are inside the hair. What do? This is the scalp. They make the hair weak and they break off. When they break off, what do you see? Only the small little tiny hair left over the scalp, which on cross section look like dots. So how does it become? Black dot. Okay, black dot. It becomes black dot, and it is what? It is ectothrix, black dot tinea. So what is the causative organism? Very frequently asked question. So it is tonsurens and violation. T and V, these are the endothrix, right? Endothrix. What is the treatment of choice? Again a T, terbinafine is treatment of choice. Now coming to ectothrix. In this, you will only have the spores only over the hair shaft. They will not penetrate the hair, right? So how will they look? They will look gray. So gray patch tinea is known as ectothrix. What is the causative organism? Microspores like Microsporum canis, right? And what is the treatment of choice? It is greaseprevir. This has also been asked. The species has also been asked. The name has also been asked. In fact, what is the next? What is the next step? What do you do? What do you do? You do KOH. What is the clinical presentation? They usually say young child. Young child has these patches of alopecia and they are itchy. They are itchy. They are scales over the scalp. In none of the other condition we saw scales. So there will be itchy and scaling, and it will be usually a young child, right? Young child, and it is a painless condition. What do you do next? Next is investigation. Investigation. What investigation do you next? It is KOH. And in fact, the picture of KOH has also come. It is if the fungal elements are inside it, then it is endothrix, right? You have to mark the endothrix species. If they are only on the shaft of the hair, then it is ectothrix. You have to mark ectothrix, right? So what is this? These are multiple tiny broken hair, right? Black dots. This is black dot tinea, right? And this is the dermoscopy. If you want to know further, so this is the dermoscopy. We have corkscrew hair. These are corkscrew hair. If you want to have a look at this image, these are corkscrew hair, not of your level though. And what is this? This gray patch. This is gray patch. This is ectothrix. This is ectothrix, right? So this was